Welcome to Sage Women, the podcast where wisdom meets empowerment. I'm Melanie White, your host, and I invite you to join us for inspiring stories and evidence-based insights that support women's health. From expert advice to real-life experiences, we'll help you to thrive through menopause and beyond. And remember to hit the subscribe button so that you get the latest updates every fortnight. It's Melanie White here on the Sage Women podcast, and I'm really pleased to be introducing today's guest, Dr. Michael Liebman. Michael, welcome, and thanks for being here.
Well, thank you. It's good to be joining you, and especially as we start on our collaboration.
Very excited to talk about that collaboration. And I guess in this episode, for people listening, we'll be talking about a really innovative approach that is going to change the face of women's healthcare.
Well,
It's a big claim.
We hope to.
Michael, could you give the listeners a bit of background about you, please?
Sure. I'm actually trained as a theoretical chemist, but I tell people I'm a reformed chemist. So I have a mixed background. I've been in academics for a number of years, and then I went into industry back when bioinformatics was starting out. I was with Amoco, the oil company, and headed up bioinformatics. And then from Amoco, we launched a DNA diagnostics company. And I worked on the original HER2/neu test that's used in cancer before there were any drugs for it, to try to figure out what to do with the test. And from there, I went to pharma. I was at Wyeth, the head of bioinformatics, and then Roche as global head of computational biology and genomics. Went back to academics for a few years, University of Pennsylvania, and then I was director of a breast cancer center sponsored by the U.S. Department of Defense, jointly with Walter Reed, where we did everything from surgery, pathology, tissue banking, all the way back to genomics, proteomics, and informatics, and then launched the group now, IPQ Analytics, and now our nonprofit as well.
Wow, there's some big words in there and a lot of history and experience. And I'm thinking for the layperson listening to this, what is the simple definition of something like informatics?
That's changed over the years. It's when I started in bioinformatics, to be honest with you, I wrote one of the very first papers using the word, and I bet something very different from what it is now. But obviously, it has to deal with information. And I actually have a figure that's been shared a number of times about the difference between data, information, knowledge, and clinical utility, and how they grow at very different rates. And so information is really clean data in my terminology, but it's not knowledge. You still haven't interpreted it. It's just a clean set of data that you can start to work with.
That's a great definition. Thank you. And it just makes me think about coming from biological sciences and biostatistics. I start thinking about the clean data and then all of the things that you can make it say, depending on what your interest is.
Yeah. There's a lot of sayings about that.
Yeah. Right. And so then it's what do we do with this data and how do we use it for good? And it sounds like you've done a lot of work and some pioneering work in the women's health space. Can you talk a little bit about that?
Yeah, I've been interested. Well, actually, it started back when I was working on the original HER2 test, which obviously we were looking at for breast cancer, and it evolved over the years, and came from recognizing, although I'm not trained in any clinical areas, that we really didn't understand disease, but we had a lot of technologies we were trying to develop and apply to it, whether it was biomarkers or diagnostics or something like that. And I actually do what I call systems modeling. And so I'm interested in looking at how big is the system, not just the question you're asking, because we tend as humans to reduce the complexity to something that makes it simpler to address. But that means we frequently are leaving out very critical pieces. And so I was looking at how to use things like the HER2 new test and recognizing that we really didn't understand the disease, that became something that I became very interested in following up on and looking at it from a lot of different perspectives because we have to recognize that the patient has a perspective, even the patient's caretaker has a perspective, but then there's the pharma perspective, there's the physician's perspective, the regulatory agent's perspective, device perspective, diagnostics, and they're all different perspectives on the same thing. But what they aren't really tending to do is to integrate very effectively across all of those views. I use an analogy that it's like having a house and having everyone looking into the house through different windows, telling you what they see, and no one really recognizing that they're looking at a house. And so I became interested in trying to see if we could build a house and then let everyone have their view. So what we've tried to do is sort of invert that data collection perspective to look at the size of the problem, not necessarily expecting that we can solve the whole problem, but we'd like to make the complexity of the problem much more transparent. So if what you are doing doesn't work, we have an idea of why and what the next steps are and can build it logically from that.
So I think what you're saying is you're taking a very holistic approach, looking at a problem from all angles and the complete size and journey of the problem, just not the symptoms or one
Yeah.
person's point of view or experience, so that you can really see what's going on and what led somebody to that point.
Well, and we like to enable then people who have those specific viewpoints to also see that these other factors could be very critical, even if they're not normally typically thinking about them, but it gives them a way to start to incorporate that and expand their view in a fairly logical way, not suddenly disruptive per se, but
Yeah.
adding on even incrementally to broaden their views.
I'm wondering if your breast cancer risk model is an example of that.
Well, it is. It's led us to look at a number of different things. So we build models. We use a lot of different kinds of technology. What I focus on is not the technology side, but it's what is the problem that needs to be addressed. And so we want to start looking at what's the question that, not even the question that's being asked, but what is the question that should be asked? And so from running the breast cancer center, what I learned was how to work with clinicians, breast surgeons, and oncologists to gain their confidence so that while we could do what they were asking us to do to contribute, I needed to know what they really didn't know and what were the questions they wouldn't stop to ask because that wasn't their training, nor did they think that there were easy answers or easy ways to get answers. So the way I describe it is physicians have to be operational. They don't have the luxury of being strategic in general. It's a generalization. We have the opportunity to be more strategic, work to find out what root cause issues may exist and whether they can be addressed. And then having identified them, then we look to figure out what's the right technology. So we use a lot of different technologies as a result, but we're really problem focused. And there's a saying by Edward Deming, who was an economist, and is if you don't know what the question is, you'll never find the answer. And that's really a guiding point for how we operate.
And so on a path to identifying breast cancer risks, what might be some of the things that you'd be looking at?
Well, what we're looking at is the breast is somewhat unique because it's one of the organs that undergoes a lot of developmental change post delivery and throughout a woman's lifetime. And as a result, what we're trying to identify is where are critical events taking place that may be years before a breast cancer develops, but are actual early triggers or setting the path for how that breast cancer may develop. Because we have been very successful, if we look at the statistics, in extending lifetime of a breast cancer patient. So the life expectancy after a diagnosis, because of all the effort on treatment, has been fairly successful in extending that life cycle or lifetime. But what we haven't had any impact on is the incidence of breast cancer. And so while survival is going up, long-term survival is going up, mortality is going down, incidence has continued to rise. And what we're interested in is understanding that whole process to understand why incidence is going up and whether there may be ways to actually intercede much earlier than what we're doing now, which is the diagnosis as an early stage of the disease. But could we actually even start to look at preventing the disease if we know what those causes are? And so that's how we're trying to build models of how women progress over their lifetime. What are the factors of their personal development that are unique to them, which could be clinical history, it could be lifestyle, it could be diet, all these factors. And then what are external factors that may be important? Exposure to toxins, environmental perturbations, things of that nature. And so we're trying to build models that allow us to encapsulate all of that data and then see how women might be identified as higher risk much, much earlier. And it's more than just genomics. We include genomics, but it's not purely a genomics effort because we know genomics is involved, but it's not necessarily the sole driver in any of this. In fact, most breast cancer, when we talk about it, only 10% of it is typically associated directly with genomics. 90% is associated with peri and postmenopausal transition.
And that leads us to that conversation of menopause. And obviously, breast cancer is one of the things that is discussed at that time, including many other things such as neurodivergence and osteoporosis and all sorts of things. Right. What are we looking at in terms of understanding the perimenopause to postmenopause journey?
Well, I use I use the Rumsfeld term that we're dealing with the unknown unknowns in that domain. I think, at least from all the women I've ever spoken with, none of them are satisfied with the information they're able to obtain from their gynecologists or obstetricians. And it's not the fault of their clinicians, but it's not actually taught very much in medical school.
Yeah.
And that comes about because we haven't had the data, we haven't had the research, we haven't had that as an emphasis on understanding it. It's just always been there and expected to be there. But if we look at something like perimenopause, which is anywhere on average 7 to 10 years in length, it's a very complex process, that transition. And it's going to impact every other disease that a woman may have in that 7 to 10 year period. So understanding it just as a process and how it affects an individual is important to manage her entire healthcare profile, not just the transition into menopause. Menopause is actually just a state transition. It means you haven't had a period for 12 months, but perimenopause is that process up until then. And if we look at it again from a systems view, where typically perimenopause it can start much earlier, but typically it starts somewhere in your early 40s. And menopause is typically around 51 on average
Mm.
now. Um, what that means, with given how lifetimes have increased over the years, a woman is going to spend almost half of her life either perimenopausal or postmenopausal. And so not understanding that is really detrimental to having the best life experience and managing everything else that the woman will experience, whether it's disease or just quality of life issues. And so that's how we've started to try to build a profile like that.
I can see that it's a complex and convoluted area to be working in, because every woman's going to have her own history up until that point. And there's the genetic side of things, and then there's the environmental side of things, and then there's the lifestyle side of things, all of which are going to influence the woman's journey through that stage of her life. And I'm thinking particularly of the data that exists showing the average age of menopause and how that differs in different racial groups. And then for smokers, they go through menopause 2 years earlier. So there's obviously a lot of things that are influencing when a
Right.
woman goes through menopause and what she goes through.
Right. And in general, in our modeling, one of the key elements that we focus on is that disease or a condition is a process, not a state.
Mm.
And so that means we need to understand that women will go through perimenopause differently. We suspect that there are probably several common paths that they may take. Now, that's not going to be an absolute identical path for every woman. There'll always be some nuances, but there will be some commonalities we think that can be observed, but we don't have the data to measure that and observe that. But what that means then is what women tend to do, because as I said before, they're not getting the information they really would like or the answers to questions they have. They turn to their friends and networks of friends.
Yeah.
And I mean, it's a very natural way to try to get information. But as I always tell groups that I talk to, your hot flashes and your friends' hot flashes are not the same. You may both have hot flashes, but they're not the same. And you have it on. There's been identified about 62 different symptoms that are associated with perimenopause. Not everyone goes through them, of course, but knowing which ones you're experiencing are going to also impact something like your hot flashes. And we treat those even as comorbidities or other conditions along with your hot flashes, just as an example, because hot flashes affect about 80% of all women. So it's a common
Mm.
experience to show you what we mean.
Yeah, it's very interesting, isn't it? The different pathways to getting to that state. And as you say, we need to look at the processes, not just the state. And I'm also thinking about treatment now, because what you're saying, if we have different pathways to get to hot flashes, for example, that means that the intervention or the treatment is probably going to be different too. Is that right?
We would expect that. So this is really personalizing medicine.
Mm.
This is what personalized medicine means, at least the way we think about it.
Yeah.
It requires having an accurate understanding of the disease. And when we're looking at how women are going through perimenopause, we're actually mapping out in our models all of the critical hormonal transitions that take place during development, which means we are going back at least to menarche, and
Mm.
we're doing a very detailed profile of pregnancy histories, because these are the most hormonally disruptive or variational periods in a woman's lifetime. And we need that kind of information to know what her journey is going to be like. The challenge we have is that data doesn't exist. And we've scoured a number of international databases, at least, especially at the level we're building models, because we're looking at, say, for instance, the idea that we know that something called null parity is a risk for breast cancer. Most people think null parity means you never had a child, but it actually only means that you never had a live birth. And when we look at menarche and we understand from the data that the age of menarche is going down, it's decreasing globally, and the age of first pregnancy is going up, that means the period of time in between them is increasing. That's a period of no parity for every woman. And so the question is, does that actually, it correlates with, but is it causal for what we're seeing with the incidence increase of breast cancer? We don't know. We don't have the data to study it. And that's the kind of data we're trying to now gather through the collaboration we're setting up with you to work with women who are interested in contributing data, contributing some, and learning more about themselves. Because not only are they going to have individualized perimenopausal transition, but that should also indicate they're going to have individualized risk for breast cancer, for cardiovascular disease, and osteoporosis. And they're not all going to have the same risk profiles.
Yeah, it's such interesting work, Michael, and I'm really pleased that we're collaborating to start collecting data. And one thing that came to mind as you're talking about that is how important it is to get good quality data and uniform data. There's so many, it's not just a matter of collecting different sorts of data from different sorts of people and trying to cobble it together, because that's not meaningful and it's apples and oranges. You really need to have a unified collection method and something that's very aligned and ubiquitous in a way to get that quality that you need.
Well, and that's actually part of our research, is how to establish what are the criteria for the data elements you're collecting. Because we work in other areas besides women's health. Women's health is the focus of our nonprofit. And we've seen that challenge of trying to put data together from different databases and understanding from work that I've done in the past that different centers may call something or define something differently. And so what we're finding nowadays with the push for big data, which everyone is looking at so they can apply things like artificial intelligence and machine learning, the data scientists, the data engineers who aren't familiar with the nuances of how the clinical practice takes place are putting data together based on data labels. And data labels aren't adequate. You have to actually understand how those things were done. And, the example that I use is looking at breast cancer. One of the areas that's very under served, so to speak, is the area of triple negative breast cancer. And you would think what triple negative breast cancer means is that you, in testing the patient, you find out that their estrogen receptor level, their progesterone receptor level, and their HER2 levels are all below the threshold. So they're considered negative for all of those. That's why they call it triple negative. But what you also find out when you work with different centers is what test was administered in one center may differ from the test administered in another center, or how they set the threshold for negative may be different. And the reality is a patient who's diagnosed triple negative in one center may not be diagnosed triple negative in another center. And that presents its own challenge for how to manage the patient, but that also propagates into drug development. If you look at the clinical trials for new drugs that are targeting triple negative, you find out that even in those clinical trials, that kind of detail and rigor is not necessarily being addressed. And there could easily be many drugs being developed today that, because of the lack of rigor in data collection, are not actually being evaluated or shown where they could be effective. And you end up with, through lack of standardization, you bring in heterogeneity into patient populations, and it washes out the effect of the drug. So you don't see that part of the population where it might work. And so it's not just that designation and the ICD-10 code or something like that, but it goes through the entire healthcare ecosystem.
And it really dilutes what's happening, and it masks things. Yeah. So then our collaboration is really important, because your goal is to collect data globally for a study that's going to start to really look at a more personalized approach for women's health.
Yeah. Yeah. So again, we've extracted methods. We borrow methods from other disciplines, as I said, because we're focused on problem solving. But then as we look at the methods, we see what needs to be adapted or expanded. So one of the methods we use is called a knowledge graph. It's a form of it's in that area of artificial intelligence. But we've expanded the approach in a novel way to look at a lot more rigor, so that it's not just a data warehouse, but something that can be made actionable in the clinic. But in doing that, these kinds of nuances, for instance, of knowing where the test, what kind of test was done, how the threshold was set, these are very detailed characteristics that we are building into the knowledge graph. And then when we build the study or the survey used in our study, we carry that over and apply that to ask the questions the correct way, to be able to know what those unique differences are. And that is very critical to being able to actually use the data we would like in the ways we would like to build models. The other kind of question that is important, I pointed out that there's 62 symptoms that are identified or associated with perimenopause. And many people, many women have had surveys or participated in surveys from different organizations or government policy, whatever, where they have a checklist to check off what they've actually experienced. And of course, these are also unique to individuals, but it's not enough if we're using our approach that says we need to understand the process to just have a checklist of what you experienced. Yeah. What we're asking is, when did you experience it? In what order did you experience it? And what did you experience at the same time? And those are the factors that will help identify an individual's journey, not just the general characteristics. And that's the kind of data that we build into the model and then into the surveys or studies that we're doing.
It's such exciting work, Michael. I can see that this is going to really be a game changer for women's health and for healthcare generally. It's going to lead for more personalized medication and other treatments. It's going to help us to understand contraindications better for medications and other treatments. And it feels like a one size fits most at the moment.
Well, yeah. I mean, one of the things we would like it to be able to do is be able to provide for a woman some guidance to know if what she's experiencing is part of that normal transition or not, rather than not knowing and not having a good resource to talk to find out. A common occurrence during perimenopause are some cardiac events, small events. But instead of running to the cardiologist, who may not even anticipate as part of perimenopause, if you know that this kind of event actually occurs in your transition, you're going to feel more comfortable with that and not immediately panic, so to speak,
Yeah.
that you're having a much more serious condition, or if you're experiencing something that isn't necessarily part of that transition, then it is something that needs additional attention.
Mm.
So giving the individual, giving each woman more control over her own experience and knowing how to interpret it.
Yeah, and it's such an important point that you make about that, the knowing and the sense of control around that, and sense of confidence, or greater certainty that comes with that, because too often we're speaking to women who don't even realize that they've been in perimenopause for the past 2, 3, or 4 years, which means they've missed an opportunity for early intervention, for one. And it means that they've been struggling with symptoms and thinking that they're going mad too, and then going to doctors or other healthcare practitioners and not getting a diagnosis. So there's this fear coming up around what's actually happening to me. And I've heard women say, I wonder if I'm getting early onset dementia, for
Yeah,
example. It's a
yeah,
real concern. So to have your work available, to have that data collection, to understand your own unique risk profile, your own opportunities for early intervention, that is really important and powerful. And we're so pleased to be partnering with you to share this data collection study and initiative with the people of
yeah.
Australia.
And we think it's well, the goal is we're running it through the nonprofit, and the reason we're doing that is having been involved in commercial operations and pharma and investment small groups and so on.
Mm.
The need to commercialize something can sometimes um, redirect how the study is done. By
Yeah.
keeping it in our nonprofit world, we believe we're doing it the way we think it should be done, and not trying to take certain shortcuts or directions that may not give us the comprehensive knowledge we're trying to get out of this. So that's one of the reasons we've moved it into the nonprofit. Um, we have other aspects of women's health that we're tying into this, of course, because we're also looking at hypertensive disorders of pregnancy and preeclampsia on their own, but then also how they impact even perimenopause much later on. So none of these things we think are isolated. It's really a continuum of looking at normal development and how these presentations are influenced from different factors. We actually in the US have been running some public forums for women in association with some of the professional women's sororities in particular. And it's just to allow women to come in and ask questions. And, there aren't really those opportunities. I know you're through your organization providing coaching, and that's a real key factor that provides some comfort, I'm sure, to a lot of women being able to find a reliable source or resource. But we think this kind of information, we're collecting it in the US, we're in discussion collecting it in Africa and in Chile as well. And so we think this kind of information and being able to do comparative analysis as well is going to at least open up new doors. I never tell anyone we're going to solve the problem, but we're going to make things much more transparent than they are.
Yeah, it's really, really powerful work. I love that you're exploring different countries and different populations and aiming for that broader transparency. And I mean, certainly in Australia, we realise that there are underserved populations here, remote populations, regional and rural groups, cold women, culturally and linguistically diverse. And we know nothing about their experiences and their life history and how that might influence their journey into chronic disease or not in later lives. So we're really excited to be getting this work out, and we'll be launching this in June for anybody that's interested in partnering with us to share the work and get women engaged to contribute information and help you with your data collection and study. That's the goal for us. And I'd love to finish on this, Michael, with understanding what your goal is for this year with this work.
Well, we've done preliminary studies using UK Biobank, the US All of Us studies, and so on. But we need to actually fill the gaps, and the gaps are the data we're trying to collect. So what we'd like to be able to do, and one of the ways we've set this up, using it as an online anonymous first pass data collection, is exactly to address the fact that you could be rural, you could be you can address it on a phone and answer the questions. So being able to link in from anywhere, it's not something that requires an academic setting or going into your doctor's office. In fact, it doesn't require anything that you should not be able to address on your own without looking up records. But our goal then is to get a large enough population that we can show the feasibility, and then we really have a much deeper set of questions we like to ask, but that will be much more involved. This first pass is what we want to accomplish this year, collecting this first set of data.
Mm-hmm. We look forward to helping you with that work, Michael, and launching this in Australia in June. It's really exciting. And I will probably come back to you later in the year for another update on how things are going and what you've learned. And thank you for your time today.
Oh, thank you. Looking forward to continuing to work together.
Yeah, it's amazing. We're really thankful for the opportunity to partner with you.